Yeah, good afternoon, everyone. I just want to make sure everybody puts in the chat box if you have a question. Marie will be monitoring those questions so that if we hit a snag, maybe a bunch of people have the same question, we'll stop and we'll answer that, review it, whatever. So make sure you put your comments and your questions in the chat box. Marie will be monitoring them. And I'd like to welcome you all this afternoon to our charge capture presentation. As an old auditor, this is near and dear to my heart. So we're going to get started. I think so. We have a disclaimer, and basically is that all CPT codes are proprietary to the American Hospital Association. All UB revenue codes are the American Hospital Association. I'm sorry, American Medical for CPT, Hospital for Rev codes. The information is provided for education and not to be used for business decisions, and it is current as of today. There are always changes in Medicare regulation, and so therefore we would encourage you to look up with your MAC or your provider or your insurer exactly what their statement is on it. So as we start today, first of all, I'm going to apologize. I'm getting over COVID, so I cough quite a bit. So if I have one of those cough spells, I'll mute, and I apologize for that to happen in advance. We want to cover the charge capture basics, and a lot of people think that it starts at the time the charge is entered, and we're going to show you why that's not true. We want to look at charge leakage and what causes of preventable services, the benefits to even putting an audit program in your revenue integrity system. Have an ability, create your own audit, and there's an appendix on this that will give you a step-by-step on how to create an audit. And then, do we want audit software? Today, the objective is to understand the process, identify charge leakage at its root, understand the importance of random audits in the identification of the charge leakage, how to design an audit program that maintains your ability to limit and to identify the root cause. That's the key to this. We want to use audit and root cause in the same sentence. So overview of charge capture. First of all, HFMA in one of their articles a bit while ago, and this is just a snippet from it. They basically said denial prevention requires corrective actions at the point the revenue cycle, patient access, clinical services, HIM, patient financial services, and in scheduling, charge capture, coding, and billing. So again, charge capture isn't just putting the charge in. Charge capture is a big world of stuff around it. And if I look at the charge capture flow, it's going to start with patient access. At one point, there was a statistic out there that 18 to 22% of all claims will fail on initial submission due to inaccurate demographics, eligibility, or authorization. So obviously, charge capture fails from the point of registration, yet we don't put a lot of effort into registration and making sure the accuracy and what have you. So auditing there will be important as well. Then the patient's attended by the nurse or the physician who will put in the documentation. Both of those are precursors to the service being rendered. And once all those blue boxes are done, you start into the charge capture process. So any of those blue boxes fail, the entire rest of this Visio chart will fail with it. So it's very important that every one of these steps be addressed. And I've broken them down into quadrants. So you have your charge capture in purple that includes CDM, edits, claim generation. I've got your scrubber and reimbursement in gold, and then where we can put in some solutions to help you. There are four things in which you can charge for, and they're procedures, 10,069,999 CPT codes. And these are usually soft coded by HIM. And this is a routine area of charge leakage, not so much in your inpatient where coders review the entire record, but more so on your outpatient where you may have a lac repair or some sort of surgical procedure minor in the ED. The patient goes home, and if there's no charge for it, then it won't come across the coder's desk, and therefore no code will be applied. So charge and coding are separate mechanisms, and we'll talk about that in a minute. Services such as lab, radiology, all those in the 70,000 through 9999 procedures codes in CPT, those are all usually hard wired by the charge master because they happen the same way every time. No variability, doesn't require coding effort. And so those are frequently hard coded. And if those codes are incorrect or they are assigned in an order entry system to the wrong charge master line, you're going to get wrong results on the back end. Pharmacy is a big issue today. One, because your drugs constitute a huge amount of your expense, and also they fail more often than not in generation of revenue, either to eligibility, authorization, or worse yet, the number of billing units on the claim. A very expensive drug may need 100,000 or 10,000 or 1,000 or 500 units in order to get paid because they're paying per unit. However, you put a unit of 1 on it. So you'll be under reimbursed significantly. Supplies are continue to be under 276. In addition, there's room and board that you can charge for, but that's not part of this charge capture presentation because that comes out of the room and board module. In all cases, a CDM must contain a line for a charge. Either the charge is going to be hard coded by CPT or it's going to be soft coded by HIM. But if you don't have a full complement of charges, you have no expectation of full complement of reimbursement. Components of charge capture include the pre-services we talked about, documentation and charge master, and then the assignments of charges. And we're going to focus on that in a minute. But there are 3 preponderant methods, which are paper, the old method, the downtime system, order entry, manual charge entry, where you're actually going in and putting a charge in through order entry or picking a charge from a list and putting it in, and then documentation driven, meaning that if the physician or nurse or other provider actually documents something, then that drives the charge all the way through. Then charge reconciliation and your daily audits. The pre-service keys to success and registration is the demographics have to be accurate. And when I listen to people at patient access, they'll say, do you still live at 123 Smith Street? Is your phone number still 440-333-3333? And so they'll give them the answer. And the patient on the other side is kind of overwhelmed that they're even there in the first place. They'll go, yes. And in fact, that's not true. So the opening, validating by probing questions. What is your current phone number? What is your current cell number? What is your address now? Can I have a copy of your insurance card? What is your insurance plan? Asking for those questions rather than just hitting some computer systems have something called demo recall, where they can pre-fill the entire registration in based on a prior visit. So this is very important that they do that. Also, I want to point out, I went too fast, never, ever, ever accept the physician's office documentation as of eligibility or authorization, because the physician's office has to get their own, and in many cases it's the same as the hospitals, but also in some other cases it's not. So make sure you get your own authorizations. You need then to move to step 2, which is documentation. You have to have the proper documentation, the medical record in the claims, important for reasons. Protect the program, this is Medicare, or the insurance payer, you're protecting that. To protect your patients, to make sure they're not charged for something they didn't receive or charged in error, and to protect the provider. Many of these claims end up in lawsuits, civil lawsuits with providers or with insurance companies, and patients will remember what great care you gave their family member, their loved one, and that you saved their life until the bill comes with erroneous things on it. And then that's all they're going to remember is the hospital tried to overbill me. And that's a story that's going to end up in the newspaper. This is all from the Office of Inspector General. Documentation best practices have the documentation present in the record prior to charge creation. Now that is a guaranteed method if you're using documentation-driven charging. However, it is not guaranteed that if you're putting in a charge that's CPT code hard cut from the CDM, if you don't have the documentation there, somebody selected the charge and now you have a charge without documentation. Occurring through the EMR also can be something you want to look at. So if we talk to documentation, the next logical step is the charge master. And the charge master is nothing more than an inventory of services, procedures, supplies, and pharmaceutical during the patient care episode of care. So hard-coded in the function that it adds charges and it adds the code, the CPT code. Generally, CDMs do not add diagnosis codes. Those are coming from the EMR, but it adds the HCPCS codes or CPT. Only those that lack variability, like an EKG, an aerosol treatment, something that you can do it patient after patient and different provider after provider, it's the same way every time. No, there's no variability. Those get hard coded into the CDM. If, however, it's a laparoscopy for an appendix, that can be done different kind of approaches, may end up being open. Those types of things in the range of 10,000 through 6,999, they're going to require a coding professional. Because it's hard coded, the labs or radiology, it's going to assume the documentation is there, the order, everything is present, medical necessity has been achieved, all of that prior to the actual test being performed. According to the OIG, and this goes back to 1998, they see outdated CDMs as a significant compliance risk for all hospitals because it brings over outdated codes. Now, not much more so, we have systems in place that prevent deleted codes from coming over, but if you have a correct code in the charge master, but it's really coded wrong, meaning you meant to get a chest x-ray 2 view and you coded it as a 1 view, it's going to be that code. Every time you do a 2 view, you're going to send off across a charge for a 1 view, and that means you're going to be reimbursed, and there will never be any documentation in the record to support the 1 view. So this is why most charge master people, they use a software system and they use a 2-layer audit to make sure that all charges are there. The other thing about charge master driven, and I've beaten this in the ground already, is that it assumes the documentation is present, and on claims review, as an auditor, I find it to be missing at least 15 to 20% of the time. So when we're looking at these charge capture methods, the old tried and true is paper, where there was a charge slip for downtime charging, whatever. Because the downtime charging doesn't happen very often, the charge slip likely gets outdated, and therefore you have the potential for putting in the wrong charges. System charging through order system or selecting a charge manually involves human intervention. And if you have PRNers, excuse me, or part-timers, they may not be very comfortable or understand how to pick the charge, and you may end up with the wrong charge. The benchmark, the system that most people in the United States, as well as around the world, have gone is to documentation-driven charging. Now, when I say charging around the world, it's those quality metrics, it's the cost metric, but it's based on documentation. So there's an order, the order drives the documentation. Once the provider puts in the documentation, overcomes the charge, the quality metric, whatever it is. And so therefore, it's a guarantee the documentation is present prior to charging. So this is the benchmark standard of the industry. When we look at EMR, one of the areas where charge capture fails is in templates. If you allow IT to create your templates and your providers and HIM are not part of that creation process, you're going to get templates that make sense to IT, but really don't document what we need to do. And a lot of times we find this is an issue when we have CDI teams going back. It's like it's not asking the provider for what we need. It can be frequent documentation is buried in an area. So I had a case the other day where one operative, it charged the time and they coded out to a procedure, and that procedure was adequately documented in the title line of the operative report. However, HIM never read the whole report, and there were 5 other procedures that they missed in the coding. So they have to read the notes. Sometimes these codes and these procedures are buried in the notes, and with HIM's queue so fast, it's always helpful to put in an extra charge for the time for each procedure, or let them know it's a multiple procedure, or your OR levels differ. So in some way, shape, or form, there's some semblance of order to make sure that everything's captured. Overcharging presents a particular concern because they charge by exception. Their pick lists and preference cards will charge everything on there, and it's up to the circulating nurse or charge capture analyst to go back through the record and remove, or by exception, uncheck the items they didn't use. Well, frequently we're finding that there was an article on supply management, 30% of all charges and supplies used from the preference card are in fact never used. They sit on the table or they were never in fact used. So the exception represents a problem. So when you install a new computer system, these preference cards are very articulate, but they, like anything, need constant maintenance. And so therefore there should be some sort of audit cycle set forth to make sure that these lists are appropriately maintained and current. Pharmacy charging, actually, it's usually not in the CPT code, the HCPCS code, or the revenue code. It's actually in the units of service. While the pharmacy module will send over the correct code that will connect correctly with the CDM, there's a mathematical calculation that occurs that takes it from the dispensed unit or the ordered and dispensed unit into a billing unit. So for example, on Dansetron, Zofran is per 1 milligram, but the vial contains 4 milligrams. If the mathematics are not correct, it's going to come over as a unit of 1, when in fact you meant to charge 4. So when we do claims reviews and I do audits on pharmacy, this is one area that I can always expect to find money in charge leakage because the units of service may be erroneous. Some of these mathematical calculations are extremely dodgy to create. And so therefore I recommend testing them prior to making them go live. Just test it out, make some fake orders, some fake dispensing, make sure it's what you want it to be. There are software systems out there that have inherent bill calculators placed in them. So you put in the J code, you put in the drug, you put in the amount, and it's going to tell you how many units should be on the claim. So those are always helpful to auditors. I rely on the Vitalware version because it's like I don't want to be using my calculator all day. Charge reconciliation has been known to be a benchmark best practice. However, nobody has the time to do it. So it's necessary in the performing department. However, it's usually not done because the daily care of patients is the priority, and staffing and acuity is also a priority. So this kind of falls by the wayside. Also, it's time sensitive. You have to have it all done before the claim goes out. And it's seldom part of a policy and procedure with enforceable outcomes. So for that reason, it's set up to fail. It's a cumbersome process. Late charge concerns are identified from claims sent back through the process if it fails. Difficult to perform these audits manually every day. And so therefore, it's required. It's a necessary step to ensure no charge leakage. However, it's very difficult to perform without significant software hold. Rule of thumb is that if it's hard-coded in the CDM, error, look for the reconciliation as a failure of the documentation to support the charge. So if it's hard-coded and you're looking for a causative agent, it's going to be the lack of documentation or lack of complete documentation. If it's soft-coded and it's by HIM for the potential HCPCS code, it's coded, they coded it from the record, but nobody charged for it. So it is important for charge capture. You must have a charge for which there's a code. One without the other is nothing at all. So you have to get both the charge and the code to the claim. So we're going to talk about the audit program. Coming back from an accounting firm, if I take the financial background type of step, it was an official examination or verification accounts or records. So pretty much everybody knows what a financial audit is. It's an examination of any result or process against a defined control point. So basically, if you're looking of your allowable costs, that's the definition. You're going to examine it against your control point of allowable cost definition. In the Medicaid Integrity Manual, Chapter 10, they talk the objective of their audits to audit provider claims to identify overpayments by ensuring that claims are paid for items and services properly documented, and items and service are using the right codes and covered by state law. So that's Medicaid. So when we look at, if we've taken it from financial over to the hospital reimbursement system, we're going to see that a revenue integrity auditor, somebody who's been trained to perform the examination or process to define set of control points and to express an opinion or judgment. Generally, auditors are known for their financial exams, but for facilities, these auditors look in the Department of Revenue Integrity and have chart review and claim review skills. Now, one of the things I'm going to point on about the audit in the balance sheet and notes to the balance sheet on your financial statements, the financial auditors will test the compliance with charge capture. And therefore, these failures in the revenue integrity side can result in an adverse opinion on a yearly audit. So we definitely have skin in the game. So what is the audit cycle? And I purposely and intentionally took this audit cycle from a different country, from a system that has nothing to do with charge capture in America. And basically, it's identify the topic, set a standard, collect the data, analyze the data, and implement a change. If you look at the guidelines for CPAs, it's the same audit wheel. If you look for pharmacy audits and making sure dispense equals ordered equals delivered, it's the same thing. Now, this came from optometry in the UK. I use it because I came from NHS for a while, so I love the cycle. However, if I look at, here's one for a nurse midwife prescribing audit, that audit cycle is exactly the same. You're preparing an audit criteria, measuring, making improvement, sustaining the improvement. When I look at this, you set the standards, you measure the practice, compare with standards, and you change the practice and re-audit. This audit cycle came from patient outcomes in NHS Lothian. So in fact, all of these different audits are virtually the same audit wheel. And that's the important thing to know. So we break down these components of the audit wheel, we see the definitions or what's the objective of the audit. Number two is absolutely paramount. Written standards, policies, and procedures. So when I go into a hospital and I do an audit, I say, give me your charge capture procedure, or give me your CDM maintenance procedure, or give me your procedures and policies for E&M calculations in the ED. If they don't exist, I've already failed the audit. I can't go forward. Step two has failed. And this is why OPPS 2008, they gave 11 criteria for E&M levels. And in those criteria, they specifically state that there are documented policies and procedures that can be reproduced by a third party and offered at any point in time. So this is one of the issues we see. Then the data elements, what data are we going to pull? Specific review of the data elements against the policies and procedures. Published findings illuminating any discrepancy. So we've evaluated it. Now what do we have to say about it? And then what is a corrective action plan, and re-audit it. So these 7 steps are pretty much everything. Now when I look at 6 and 7, we are well known in the hospital revenue cycle for finding a fire, putting the fire out, and going back 6 months later and seeing that that issue is still smoldering. It's either gone back to the way it was, or people have reverted to a prior course of action, or whatever. So 6 and 7 go hand in hand. If you correct it, you need to make sure it stays on the tracks and it doesn't derail at some point because we've gone back to our old ways. The importance of the audit cycle is an expectation that every audit follow those steps. No deviation whatsoever. The step requires amendment or change. It must be noted as a variance. So one of those variances is you're going to look at the AAUC requirements for radiology in the ED, but you don't have the requirements. Okay, that's a variance. The audit cycle can be implemented for any charge capture using those steps. And too often a measure has a root cause which is remediated, but never the re-audit was never conducted, so you go back to the way it was. So when we're looking at these standards and measuring the current practice, those are basically setting the framework for the audit. And when we're looking at specific considerations, one is the audit, the universe of the population being examined. So what is it we want to audit, and do we have the entire sample? Do we only have a portion of the sample? What is it we want to do? What would be the correct amount of records to make sure it's statistically significant? So if you're in doing a compliance audit, you have to be 95% accurate and 25% consistency. You have to meet some very rigid audit standards that you're going to need a statistician for to pick the sample. What if the facility is variable? So say you have somebody, a hospital that's in the mountains of Colorado and very well known for orthopedic injuries in the winter from skiing, but you don't have much in the summer. If you pick the audit to be the summer months for the Department of Orthopedics, you're not likely going to get the university sample. So you have to make sure you've adjusted for seasonal variability. Statistical reliability and precision, we talked about that with the OIG. And what you're trying to find is a pattern of behavior. What is it that shows up over and over and over again, and then find out what that root cause is. Any other consideration will result in a less than specific selection. So will the selection be by software or charge capture claims that do 100%? So there is one method if you're going to do random audits, just to check to see how you're doing, get a litmus test, and that's called the nth selection, where you select a record based on the nth number it occurs in a sample. Say you want 100 records, you take the digits for the month you're auditing, say it's October, then every 10th registration until you get to 100 records. So just keep going through, every count out 10, and every 10th you go to 100 over the 12 months. So then you compare it with what the standard says. So say I have a standard that's a national coverage determination for a TAVR, then I'm going to go ahead and I'm going to look and see that what is it that I need to make sure for medical necessity. For example, you're doing an ED E&M record. The standard's going to be a point system, and that point system is going to be an nth record selection. Your policy and procedure will be based on 2008 OPPS guidance for creating an E&M leveling tool. Another example is radiology exams. Select a portion of the exams that require medical necessity determinations, and then you use the nth randomization. So for example, mammography has a frequency limit. You might want to select a mammography population and check the frequency limit, making sure people are not receiving them more often than they should. You're meeting medical necessity. MRIs against the Medicare payer guidelines to assure the documentation is achieved and medical necessities met. Now, that's the nth method, because you're going to do it by paper, Excel, something like that. However, there are software systems out there that will take 100% of the, and that's not the university, it's universe of charges on the claim. So it's going to take in every single charge you put out every single day. It's going to run it up against records, either they're 837, your claims, or it's going to run it up against your charges, and it's going to point out those times where errors are likely to have occurred, where there is something not quite right according to the algorithm. So say you have 5 CPT codes and all 5 of them are for OB, but then you have a CPT code that's in the 3.3 range for cardiac bypass. The cardiac bypass is not an eventual portion of that universe of claims and would single itself out. So obviously you can do 100% with the software. Changing the practice is where I come in. This is your basically your root cause remediation, putting a new practice plan in, making sure there's an audit set up for the past part. So you're going to say, you know, your findings, positive findings. Is there identified singular aberrancy, or is there multiple reasons this is happening? Goal is to get to the root cause and remediate the error. So there's a lot of computer systems out there and a lot of hospitals I know that work through a queue, be it their own internal software or a vendor, and it populates a queue with these aberrancies every single day, and the people just work the same aberrancy over and over and over again, and the root cause is never determined because it's in a revenue integrity is doing it in a silo and not really pointing out to the Department of Radiology, this has happened 23 times. This is the amount of money that's worth, and we need a root cause. Sometimes it's the ordering system. Sometimes it's provider education. Sometimes it's the AUC documentation. So you have to find the root cause and get after it. Then you remediate it. And I like to use Six Sigma. I'm a little fond of that. There are other methods to do, but it basically you look and you see what exactly happened and ensure that you have the best foot forward. So one of the easiest way using Six Sigma, and this is a very basic tool, is you ask the question 5 times. Why? Why is something happen? Oh, because of X. Why did X happen? Because of Y. And you go through that 5 times. Generally, at the end of the process, the true root cause is found. However, if you look at that root cause versus at step 1 or 2, you likely are going to see a huge disparity. So here's an example. You note a joint implants on the claim, but there's no procedure for a joint. So why is it there? Because it was charged by the OR from a preference card. Well, why was it charged if no procedure? Well, because the PICUS was on the wrong patient. Well, why was it on the wrong patient? Oh, they had the same name as another patient on that same day. Why did that happen? This is now we're dealing with identity issues. Why can this happen if there are policies and procedures? Well, failure to use the patient identification per policy, claim needs to be adjusted, the nurse needs retraining. Now, obviously, when you came into this, you didn't think it was a patient identification issue. You thought it's like, okay, I charged the wrong thing. But having the 5 whys, you see what really did happen. And this actually was a real case that I came across that I'm using it as an example, obviously de-identified and dummied down, but this is an actual thing that happened. Remediate the issue. Once the root cause is found, it's time to fix that. Corrective action plans are put in place but fail because all of a sudden you have a system upgrade, or the CFO wants something else, or you're starting a new service line, you get distracted. So I call it the shiny object syndrome in the hospital. This was shiny last week, but now it's kind of dull. We got to get on to the next thing. Ensure remediation is written. Word of mouth is an almost guaranteed way of failure. That's why we like Six Sigma. They'll put it in a project plan. It'll be well documented what happened so that you can go back 6 months from now and find out where it came off the rail. And then you have to look if further changes are needed. Generally, the first attempt at remediation is a yeoman's job, but you don't always successful. It needs to be fine-tuned. So then we, of course, talk about the re-auditing. So if I sum these 5 steps, it's the same no matter what type of audit is being taken. Billing, chart, financial, charge capture, compliance, patient quality, doesn't really matter. The key elements are the establishment of a standard, comparison of that standard to what's actually happening, formulating conclusion, and that conclusion may be you're spot on, everything's fine, and you just go back and you re-audit it temporarily every now and again. Or you can say, you know what, this is the finding is that it works for a bit and it doesn't work, and so we need to keep the process going. The ultimate goal here is to compare the record or the benchmark to the charges on the claim. Were they ordered? Were they medically necessary? Were they documented? Were they documented as provided? And yada, yada. One of a perfect example that people still struggle with is IV infusion. And the reason being, when I go into most of these medication administration records, the stop time is in fact not a hard stop. The start time is assumed to be the time that they sign the drug off with the patient. However, there's no stop time. So they can sign off that as a provider or a nurse or whatever at the end of the shift and never be required to go back to that stop time and say, well, is it finished? So what you see are IV infusions that went for 5 days, because that's when somebody caught the stop time. So these are real true to life thing. So when we talk about software, auditing's time consuming, and HFMA says 1 to 5% of the bottom line is due to lost charge opportunities. Makes a need to tighten it up. Industry benchmarks combine real-time software reviews with daily charge capture. While software does perform a day-to-day, the need for in-depth focus audit of problem areas remains in order to create the rectification. So software is going to point out those patterns of behavior for which you need to address. Software must consume 100% of your daily charges and your daily coding. Otherwise, you're only going to get a skewed answer. So if I'm looking for the reason for denial and I see just a portion of the sample, then that reason for denial is not complete. I may want to go and look at something else. And this happens a lot for medical necessity. So when we set the standards, we've got all the standards in the software. You measure current practice, well, you will get daily files coming in from your 837s, your 835s, your itemized charges. You're going to get these daily files. Compare results with the standards. Utilize software, almost immediate identification. So this is just a very way that consumes the universe of data, and that's the goal in being able to create the audit. When I compare against the standard, you would see, okay, I've got IV therapy, I've got this issue in IV therapy, I've got supplies, I've got blood bank. These are my areas where there's a pattern of behavior for which I'm going to need to investigate a root cause. I'm doing pretty well in chemo and diagnostic radiology and lab. Surgical services a little bit, but those med-surg supplies are a problem. Why? Vendors change supply coding all the time. And so therefore, what was a C1776 might be something different today, specifically in the area of cardiology with sheath catheters, guide wires, electrode probes for EP studies. They're constantly evolving at a very rapid rate, and you'll end up with different codes on them than what there should be. Root cause by department. So say I now have a root cause, and if I go back, well, I don't think, yeah, I can. And I see blood bank's a problem, then I just pull up blood bank, okay? And what's going on there? Well, I see that a lot of these are a business practice where we have a policy or procedure that's affecting the appropriate use of blood charges. Then I have charging issues, okay? In the ED, there was one that didn't get charged, or Adele, the administrator, queued it up wrong. So this is an issue. Then I re-audit it, and utilizing the software re-audits more often depending on your software's designed and your billing system. So I will use Epic for an example, not to call out Epic, but to say that you can create a lot around the Epic functionality based on your customization of the product. Therefore, if I was to audit one Epic system, I'm only going to be able to audit one Epic system. If I go into HB Resolute or PB Resolute, I'm going to get the basics between clients for Epic, but you may have culturally done it a little bit differently. Your work queues will be different. And so there you have different approaches. The key here is you have to get 100% of the data on Epic, every single piece of data you can get. And then with a manual audit, you can do random sampling. And there are free sampling things out there in Excel templates to do random sampling. There are free ones that you can pull down. So as we come in, and we're actually going to have good time today because I moved a lot of it to the appendix. The charge capture includes all the documentation, charge master, and charge entry necessary to create it. A CDM has to be accurate and complete. Mapping between these is a big issue with the CDM. So for example, that radiology that I talked of, the 2-view chest x-ray, but when you ordered a 1-view, the mapping between the order and RIS was incorrect. So the order said 2-view, but they linked it to a 1-view. Maybe the 1-view was completed and it charged it wrong. Maybe it wasn't. So you have to look between the ordering to the area of clinical documentation, be that the radiology module, the lab module, the cardiology module, the ER module, the OR module. I mean, there are tons of them now. And then how am I going to make sure that that process is correct? Then reviewing charges, there's two models. You've got that random sampling, and then you have the concurrent 100%. Clearly, if you're a financial auditor, you want to see the 100% review of all charges, because that's much more statistically significant than the random audit. And we still need to make the risk for an ongoing priority for revenue integrity is there. So achieve the best practice by documentation-driven charging, daily reconciliation, ensuring charges are connected to the soft coding processes, 100% of the charges against a rigorous standard, early identification of root cause and corrective action, and ruthless pursuit of a clean claim. So you have to be able and willing to recognize your backyard. If you're seeing issues, what I hear a lot of times is, well, that's not key to our revenue cycle. That's not a big producer. So let's focus on something else. And that's never a good statement. If you find an error, it's an error. If you find an error and you know it's an error and an auditor outside finds the same error, that's a problem. So there's a big difference. What I've done here in the addendum, and I'm going to quick look and see, Marie, do we have a lot of questions, a lot of Q&A?
No, right now we actually only have one question, so you have lots of time still.
Okay.
Yep.
So I'm going to go through this addendum, and this addendum is actually a random sample audit I set up. So we're going to use the 5 steps. I decided, what do I want to focus on? High dollar claims, COVID-19, how many are being stuck in the scrubbers due to dynamic billing guidance, supply coding, areas that are frequently failing in the initial scrub, and therefore you find billers are taking the thing off or adding things. High volume areas, radiology, operating, services, ED, and generally in the red cycle, I see services specific auditors, meaning somebody's really good with OR, somebody's real, and that includes anesthesia, recovery, all of that. Somebody's really good in radiology. Services charges are not driven by documentation is where I would focus, because there you're going to have a higher level of failed documentation where there is an order, there's a charge, and the documentation may or may not be there. And if it is there, it may or may not be complete. You have to set the standard. So with the cath lab, here's an example of what I call cross-match coding. Part of it is hard coded and part of it is soft coded. So you may have 480 that says cardiac cath diagnostic, and it doesn't have a CPT code. It just has a charge and a price and a revenue code. And HIM will do it. Or because it is a specific CPT code, you may have a charge that says diagnostic cath with a CPT code. Sometimes I see them both in the same charge master. Hopefully that's not true, and you pick one or the other. So if it's going to be HIM coded, you have to make sure that they can get to it in a timely fashion, and they're going to be able to pick the CPT code from the documentation. Your templates are correct. If it's hard coded, then the question is going to be, who's going to review that to make sure it was right? CPT and HCPCS coding, Coding Clinic, Dr. Z, all of these are the standards. They're published source authority. So medical necessity from the MACs and from your payers. You want to use a source authority. What you do not want to use is somebody's published article. You don't want to use some article that you read or some non-revenue cycle source authority or no federal register. You know, this publication came out and it says to do X and Y. Well, who wrote that published? Well, it was John Smith, RN. Okay, we don't know if John is citing source authority, but we sure as heck know if it comes out of the Federal Register, it's source authority. So always stick with source authority. And Dr. Z would be one that I would throw in there. You measure the current practice. So standard, you look back and daily software identifies a catheter with C1726 as not being consistent with a transluminal angioplasty. So just about every one of my transluminals are spitting out the fact that the C1726, it's not consistent with that procedure. Once I go drill down, the EMR finds that in fact TPA of the circumflex artery did in fact occur. Coding reflects PTCA per coding guidelines. Okay. Attention then is given to, so that's the right code for the procedure. So I only have two choices here. The procedure's wrong or the code for the supply is wrong. So now I'm going to go back and I'm going to look and say, okay, was the supply coded right in the CDM? And when we look at this, we see that the C1726 is an Evercross, and we see that it is stated to be a non-vascular. Well, it's the coronary artery system is much part of the vascular system. So we now know the supply is wrong. When we go back in, we can see they're all listed. When we pull the model numbers up or we go to the vendor website, they're all C1725s, not C1726. And so the issue here is the procedure's coded correctly, but we are charging the wrong supply every time. Now, why is that? Because usually the cath lab has a preference card very much like the OR. And when they pull a balloon catheter, it may have been coded as C1726 by the supply chain. In fact, it's C1725. So every time they use that or perform that procedure, we're sending out the wrong charge. That coding error is just as bad as if you charge the wrong procedure. Remember, the claim is to be accurate in all ways, and the documentation must be supported. So people say, it's a supply, don't worry about it. Well, you line itemed it out and you sent it over and it is wrong. So I think you should worry about it. So this is an example for that. I'm going to re-audit it after I make it C1725 and make sure that the cases are going down and it's been remediated. I also have to look and say, is this worthy? Was I paid separately? Is this going to result in an overcharge, or was it bundled, or, do I need to send reimbursement back? Or maybe if it's the wrong device and the device you charged was a single chamber pacemaker, but you put in an AICD, which is $20,000 more, and you're getting paid by a commercial payer and a percent of charge, then it's worth resending the claim through corrected. So you're going to have to look at those. So here's an exercise stress test. You look at the coding guideline. Coding guideline suggests that radiotype isotopes and stress agents should be billed with a procedure. Okay, and the procedure is 93017, stress test. If one of these are present on the claim, then which satisfies it? You measure the current practice against the standard, and is that really what's happening? You compare the results against the standard. For those using software, it'll likely consume 100% of your results. If not, you're going to have to do an nth method and look and see. So the aberrancy occurred, and now I need to start the 5 whys. Why is there not a charge in the cath lab CDM? Because we're supposed to have an explode code. Why is there no explode code? Because compliance avoids explode code. Why is there an alternative method of charging established? Because cath lab didn't know they needed to do it because they were told by CDM there was an explode code. So basically the 5 whys here lead to an examination that results in the hospital silo complex, meaning X and Y assume that something's to be done, but they assume wrong. So this is another example, and I'm going to fix those slides when we download it, because it seems some of them went off the grid there. I have to create a remediation process, document your coding standards. So basically, when you do these audits, it's very important they be written, that they state what coding standard you used. If it's a software, it's pretty easy to find, but if you're developing your own, it's very important to say, I use CPT Coding Clinic, I use CPT Assistant, I use whatever. Ensure the process includes ability to credit one or both parts of the explode code if it's not utilized. So, for example, the last one was a radioisotope. Say they started the stress test but never got to the point of the radioisotope, patient got sick. Now, if there was an explode code, you'd need to make sure you have the ability to credit the one component. You have to monitor and re-audit the process, make sure that it worked. Here's another one, decreased revenue in the ED. This is a real example. In this ED, the manager comes to you and states there's suddenly a decrease in the revenue department gross volume, but the trend in gross charges, but the trend is up in the volume. So you know the manager's being held for their gross and net charges, so they can't figure it out. The manager states in the month of July they had a lot of acuity based on their staffing model, so they were all level 4s and 5s, high acuity. You do not include current software, and so therefore you set the standards. You're going to use the point system they defined in the policy. And measuring the current standard, you employ the nth method, you reach 100 records, and you determine the median level 1, 2, 3, 4, 5 for the 6 months prior. This is what you see in Excel. That the standard was 5% level 1, 15 level 2, 30 level 3, 20 level 4, and 30 level 5. However, usage for revenue and usage breakdown for July says they're all 100% level 1. You didn't have a single 2, not a 3, not a 4, not a 5. So something happened in July where your point system went wonky. Compare it against the standard. Well, here's what the standard should have been. Since the records agree and the acuity staffing is 5, what is implemented? So why are they all 1s? The documentation recommends a 5. The acuity standards that recommend a 5. So why are they a 1? Why did the calculator do this? Because the calculator was disrupted during an upgrade. Why was it disrupted? Here's your 5 whys. Why was the calculator disrupted? The vendor failed to upgrade. The vendor upgrade failed to fully complete. So it was upgrading and it failed at some component. Why did the vendor upgrade fail? Because ED and IT need to refresh the system. Why did ED and IT not refresh? Because the ED thought IT would do it. They had no idea they needed to do it. So this is a real example where 5 months went through this system. They only had level 1s. They were bleeding revenue in the ED, and it was due to a systems upgrade. All of us on the phone today, I think you can pretty well associate with a systems upgrade gone awry. And this was a real example. So what would we do? We changed the practice. We rebuilt the claims back to July, included a new action task in the project plan. Whenever there's an ED upgrade, there must be testing. So they have to do it in the test system and then refresh the system. They have to re-audit immediately after to ensure the point system is functioning and continue to audit the nth random sample each day for a week as you're required to make sure that it is actually working. So at this point, I do have time for questions. I have one that says, thanks, I had the same question.
There's one question in the chat that asks, how long should you wait between audit and re-audit?
Depends on the severity of the problem. So if you have, say, a lab medical necessity and it continues to be a problem, then I would say do it fairly frequently, no less than once a month. If, however, you have medical necessity and your first 3 nth sample audits state that you're at 99% effectiveness and compliance, then you can do it once every 8 to 10 months or 6 months. It depends on how severe and how likely it is to fall off the track. I would say with every single systems upgrade or patch, that anything that it touched has to be re-audited just to make sure it's coming out right. And you don't have to do 1,000,000 claims. Do a day's worth of claims, look at every 4th one and say, okay, does this make sense? Here's my written standard. And now what is that match the standard? If it doesn't, then you get to IT. I think the problem is here is IT tests the system from an IT standpoint, and it is 100% compliant. However, the outcome is going to require a clinician or somebody in Rev Cycle to be able to tell us the difference.
Okay. Well, we actually don't have any other questions right now, Bill. Let's see, one just popped in, actually. Can anyone tell me how they handle oxygen charging for inpatients? I found this to be a problem when I did audits.
So it is a problem. Your commercial payers will say, don't charge it. If you say you're going to do oxygen per hour, then an auditor is going to want to see documentation that the patient was utilizing and it was medically necessary every hour. If you see PRN oxygen order and you're charging per day, I mean, that doesn't equate. I mean, how much of the day did they use PRN? So I think oxygen has been an ongoing issue. Most people now put oxygen because the commercial payers really are giving people a grief with it. Most people are putting oxygen into the daily room and board charge. Just take the number of oxygens and divide it out. Some people will then tell you, well, it's not compliant because I have a patient that's not on oxygen. The key to this is you need to write a standard, a policy and procedure that you can give to an auditor and say, this is why we do it. They may not agree with you and they still may take the charge off, but remember, it's not going to be a reimbursed charge. It's just going to add to your total charges. It makes sense if you are in fact a percentage charge payer, but most people in percentage charge are still going to take out 270 anyhow. So you need to look and see how much of a business is this really creating, or is this just creating a statistic? If it's a statistic, then go in and, you know, most CDM people say don't do it, but you can go into your ordering system and you can just put a statistic associated with how many people were on oxygen for how long. That's probably the easier of the methods to do, but it clearly is based on your payer sample because oxygen is a medically necessary supply. CMS does not mandate that you do or do not charge for oxygen. They certainly don't give you any guidance on it. It's all coming from the commercial payers.
Great. Well, we have a couple more questions, but we're at time right now. So I think we should probably answer those offline, Bill.
Are they the same one?
They are not the same question.
Okay, one's ventilator awaiting transfer and able to be extubated. Remember, a ventilator's first day is not a chargeable item in the ED unless you're an inpatient. If you're an outpatient, you have to be for observation or inpatient, so it's not a billable item. And the other one's a thank you, for which I appreciate.
Yeah, the other one came into the chat. And they said, what type of staffing structure would you recommend to roll out a charge capture audit program in a large multi-hospital organization? So
that's a wee bit difficult to answer in this context. I'm happy to take that one offline if they want to talk to me about their specifics.
Great. I will connect that for you then. On that note, I think that is all for today. Thank you everyone for joining us, and we hope you enjoyed the session and found it very informative. Like I said earlier, we will be posting the presentation and sending out the CEU certificates and the link to the presentation recording. So thanks so much, Bill, and thanks everyone for joining, and have a great rest of your day.
Have a great day, and thanks for joining. Bye-bye.